Okay, we'll go ahead and get started. I think we have quite a number of folks that are in attendance. My name is Greg Everett. I'm the president and CEO for Payer Compass, co-founder in 2013. With me today, I've got two distinguished industry professionals. I think everybody knows both of these gentlemen. First, I have Dave Chase, a co-founder and chairman with Health Rosetta. Really no need for an explanation on Dave's role in the market. Scott Haas, Senior Vice President of USI. Both have been supporters, collaborators with Payer Compass on a number of opportunities that we've had. We appreciate their guidance, their collaboration over the years, and brought them today to share with you some industry insights that they have about where we're at post-COVID in 2021 and what self-funding looks like. And so I'll go ahead and turn it over to Dave and Scott and let them speak about a brief intro. So go ahead, guys.
All right, sounds good. Thanks, Greg. Appreciate being invited onto this and have enjoyed the collaboration with you and your team. Let me just start with some good news. It's not like we've been in an environment over the last year of lots of good news, although certainly it's great how things are going with the vaccinations right now. But I'd share three pieces of good news, and then I'll hand it off to Scott to provide a little additional introduction. Number one, we are already investing more than enough money to not only fund a world-class healthcare system, but to fund or restore funding to what drives 80% of health outcomes, which is not the sick care system, right? The things that drive 80% outcomes, sometimes referred to as the social determinants of health, things like having a decent paying job, having educational opportunities, having a decent home you can live in a safe neighborhood. These are the types of things that actually have a profound impact. So we can actually fund both of those if we're smart about it. Unfortunately, we're masters at wasting and squandering money. And so as you'll hear, there's great ways to stop that, and it's very proven. Number two, kind of related, second piece of good news, healthcare isn't expensive, despite what you've heard. Why can I say that? Well, clinicians only get 27 cents of every dollar. Isn't that healthcare, right? Sure, there's some other costs, but should it really be 73 cents? And so that's the thing, when you get to the actual care, it's not all that expensive. And the third piece of good news is healthcare is already fixed. This is both a true and aspirational statement. This is not some new concept. I mean, if you look at the example that Scott will go, and we all go through with Pacific Steel later, it's been a number of years. The focus of my TED Talk, I mean, this has been in place 25 years. It's not yet the mainstream. That's the aspirational piece. And that's really our challenge, is all the solutions have been invented, they've been proven. Now it's our challenge to replicate them. And that's why, when we started our organization, our community with Health Rosetta, the tip of the spear for us is benefits consultants, benefit advisors. I wrote a piece in Forbes entitled, "This Job Could Save America." I believe that the benefits advisor role is the most underestimated role in the entire healthcare system, probably by extension, the entire US economy. And so we've been fortunate to have lots of interest of people who want to be in our program. We've accepted in about 15 or 18%, that have had the alignment and skills that we need. Scott is sort of a template, if you will, of what it means to be a high value provider of consulting and advisory services. And it's important to note that we're not asking anybody to take a vow of poverty when they do these types of things. And they can have a very healthy, nice business while doing right by their client. And so I'm going to just pass it off to Scott, maybe just do a little introduction, Scott, and then we'll pass the baton back to Greg.
Yeah, thanks, Dave. I think one of the key things that I wanted to focus my comments on is relative to the title, is what changes should we anticipate in 2021 and beyond in the self-insured marketplace. And I think continuing the message of good news that Dave initiated in his comments is that in a very strange way, COVID created a disruption that many of us in the industry have been trying to create pretty much for most of our careers. And that disruption was the tearing of the Band-Aid off of the scab called fee-for-service funding of healthcare and healthcare services. That also exposed another gaping wound in employer-based healthcare in the United States. If you guys all recall, just a year ago, we were at 14% unemployment because of the impact of COVID, the government's reaction to the COVID, upswing in cases and infections, to a point where there was approximately 40 million people who became unemployed. And of that 40 million, 10 million of them lost their employer-based healthcare coverage. And during that period of time, there was another, byproduct of that transition, and that was on physicians, especially independent physicians who are in a fee-for-service environment, who saw their practices go from a level of normal utilization to zero within a very short period of time. And there became then a lot of reaction in the marketplace that was quite interesting to watch and to observe. And a lot of that was movement from, face-to-face encounters with physicians to telemedicine. And while, that was all good, this disruption was created, and there's been a lot of new entries into the marketplace to fill those access gaps. There were a lot of, physicians specifically in the communities that serve each of us as patients that were quite honestly very harshly impaired from a fiscal perspective. And as that occurred, what we also began to see was greater acceleration of movement away from fee-for-service to prospective payment methodologies, especially in primary care. And so, we being our consulting practice within USI, we have always been very supportive of primary care in any way, shape, or form, whether it be on-site clinics, whether it be direct primary care, and more importantly, I think in the employer marketplace, advanced primary care as it's evolving and as it's being defined in the marketplace. So, again, tapping into what has happened in 2020 continues into 2021 that is beginning to shape the self-insured market. I think it was COVID and the influence that it's going to have on where we end up, because one of the things that we are very focused on, and I think all of us should be thinking about, is, what is the actual risk that is to be addressed and managed within the self-insured marketplace, especially when we're looking at beginning to capitate components of the funding mechanism that we typically are used to within a fee-for-service market. So if you consider that we begin capitating primary care, which represents, let's say, 30% of the total healthcare spend, and within that 30% in a fee-for-service market, 70% of that is specialty. When you capitate primary care, you move it from fee-for-service and you flip it into a capitated model, what you immediately see is that about 70% of the services are now provided in a primary care setting rather than a specialty setting. And how does that begin to then reshape what we are looking at in our communities as we begin to structure what truly is a self-insured plan? What is the role of the plan sponsor? What are the role of primary care doctors? What are the role of specialists? And how does that ultimately impact these hospital-centric systems? So I think that's where I wanted to really, create a jumping off point for discussion with Greg and Dave, and then questions and input from the gallery.
Thanks, Scott. I think, good transition. What I would say for Payer Compass, what we saw last year, there was an attrition with employer-sponsored healthcare as employers, either we had a number of plan sponsors that, filed bankruptcy. Their businesses went out of business. Our TPA partners in the process felt some of that attrition. Then we felt, the benefit design, away from a traditional BUCA network into an RBP setting. We saw that as a fundamental plan design shift that we've seen improve over the last few years. And I think we had an example that we wanted to share first before we got into the specific plan design changes that you guys see, whether it be capitated and like, of an employer group that's been with us for quite a while. Do we want to go ahead and share them? This, yeah, there we go. And Scott, this is your plan sponsor, your employer group. You probably could talk best to this than I can. So let you and Dave comment on this slide.
Yeah, what you're looking at here is the overall trend of a group that's about 720 employees in multiple locations in the Intermountain West. And none of these locations are in large metropolitan areas. And if you look to the far left, you can see the December 13 mark. That was December 13. So that was the last month in which a PPO network was in place on this particular group. Beginning January 1 of 2014, this group embarked upon a reference-based pricing strategy. And you can see then that each of this is a regression analysis. So each of these points represents the PEPM of a rolling 12-month period of time. So you can see then that as this group progressed, that there was a marked deceleration in the overall cost of the plan. And during this point in time, there have been 0 benefit changes made to the medical plan. Okay, so you're looking purely at the concept that if you want to pay more or pay less for healthcare, you pay less for healthcare. Now, what I would also point out in here is that if you look then in the yellow line, it goes from the left side and it basically moves up to the upper right-hand corner of this graph. That is the trended per employee per month had this group stayed in a PPO environment at a 5% inflation over this period of time. So, projecting out, that would be at $1,156 per employee per month would be what the spend projected out to what this plan would be paying. And that equates out to $9.4 million annually with the current enrollment. But then you can see the red lines, which are the actual trends for the group, the actual paid basis performance. The group ended at December of 2020 at $444 per employee per month, or $3.6 million. Now, this is an interesting group because we did start at 100% reference-based pricing. Some employers have that risk tolerance. Some of them have the stomach for it. Some of them want to manage the disruption. This group wanted to take it on, and we had full commitment from the C-suite to do so. The key to this, though, is that over this period of time, what we've been able to achieve related to contracting within local communities is we now have in excess of 5,500 safe harbor agreements with physicians and other ancillary providers in the local communities that serve this client. In addition, over this period of time, we have engaged 8 direct contracts with hospitals or health systems that have also then minimized disruption but as you can see, continue to basically allow this group to achieve positive fiscal outcome and spending. Now, one thing I want to point out is during this period of time, we have continued to have large claims. Keep in mind, reference-based pricing is another version of fee-for-service. It's just basically creating a different baseline from which claims will be allowed and paid and finalized through a process that is relatively fine-tuned at this point in time with this account. But the key to point out is when you see these peaks and valleys, you know, what I'm really trying to get across is that there has been no absence of large claims. It's just that those large claims have basically not materialized in catastrophic claims because they're capped in what the exposure ultimately is, and ultimately you're paying less. To a point where beginning, I believe it was January 1 of 2017, we have had 0 stop loss attachments, even though we have had cancer claims, we have had heart claims, we have had premature babies. We have 2 of them that are in this data, premature twins that are reflected in this data, that we've not had an attachment, and we're set at about $215,000 on a specific only basis. So to give you an idea of really what we're getting to, you know, we used reference-based pricing as a means to an end, and that means to an end was to get community-based safe harbor agreements with physicians and ancillary providers, and to get the dialogue and the attention of health systems that are throughout this region, that we can sit at a table and have a rational discussion based upon data and information, based upon, rather than subjectivity of you know, the provider PPO contracts that exist within a BUCA or standalone PPO environment. So I'll stop at that point for comment and input from Dave and from Greg.
Yeah, I mean, I just add a couple brief points. One, riffing off of what Scott just ended on. You don't get 5,500 agreements in place unless, and they're not some monster employer. They're not Walmart or something like that. I mean, it's a 700+ person organization, you know, ostensibly not having huge clout. You don't do that unless it's an incredibly simple and fair agreement for both sides. And that goes back to my point on, you know, healthcare doesn't have to be expensive. And that is a fundamental. And you can remove pain points for healthcare providers. They have an awful time in this era of high deductibles collecting accounts receivable from patients. It's awful for them to get paid in a timely basis. You can help address those things. And broadly, these type of things are really where we got the blueprint, you know, that we've then shared. It wasn't, you know, I live near a beautiful snow-capped mountain, 12,000 feet. I didn't have to crawl up to the top of that and cross my legs and dream this stuff up. It's happening in every corner of the country. Rural settings, urban settings, public organization, public sector, private organizations, large and small. And so we're just, it's so important. We need to get that out there, and you know, we can't do it without the kind of alliance that we have with organizations like Payer Compass and Scott and his team. That's where it really becomes a team environment. So that's all I'd add on to the end. And so Greg, you can take it from there.
Yeah, very good. Thanks, Dave. Scott, I think, you know, it's a good story. It talks about where we're at in terms of more acceptance, right? So where I was going for 2020 is, you know, there was a lot of disruption with the COVID in the employer market space. You know, people were unemployed. There was, you know, a lot of business that were shuttered as a part of it. Difficult to operate in a lot of environments with it. But what we saw for 1/1 was, you know, more the basic plan design, which this one employer group had accepted, you know, and pursued many years ago. We found more employers looking for an RBP design in the way that our blueprint has suggested. I don't want to, you know, turn the page on 2020, and that's the past. COVID is, you know, immunizations are increasing. People are more comfortable about, you know, where we're going to be able to restart. There's a yearning for people to want to be back out in the marketplace. I know I am. I'm ready for to hit the road. Want to be able to visit my clients and as we look to 2021, I mean, what do you guys see as the additional? You touched on capitation and in the primary care market, what we've seen over the last couple of years, Scott. But what additional plan design changes do you see that are going to be pertinent for us in moving forward this year and beyond?
Yeah, I think at least where we're heading with our clients and discussions in the marketplace are more focused on helping create alternative delivery and alternative financing of healthcare. And, you know, priority number one is the conversion from primary care fee for service to advanced primary care. And when I use the term advanced primary care, I'm distinguishing that from direct primary care. And that advanced primary care is a true value-based primary care medical home environment in which there is a support mechanism that is supporting the independent primary care physician and is able to basically expand the amount of time that physicians themselves are spending with their patients to a point where the service extenders that are part of the value-based model are then able to really fill in those gaps in the relationship gap and the support to the primary care and the patient. And so that kind of takes me into a topic that from a consultant's perspective and a broker's perspective is extremely frustrating. If we took every call from every shiny object that has emerged based in, coming out of this COVID environment, because people are all working at home, they're working remotely, they're extending out, to brokers, we would do nothing but basically vet solutions and service providers. And so, one of the things that where I'm going with this is that you really have to evaluate and validate a lot of these organizations from a perspective of, are they a fronting entity to a TPA platform, and do they even know how to pay claims? Anybody can slap an app on the front of something and call themselves a third-party administrator and basically make sure that they're hitting all the buzzwords. But how do we create responsibility to the marketplace and to our clients that a lot of these vendors actually are able to provide the outcomes that they're presenting and achieving? And there's a lot of money behind these organizations. And, it's almost like you get to a point where, the response from a brokerage perspective is more of a defensive response is, come back in 3 years once you have a track record. So the reason that I'm getting to that is that these organizations are still coming from the outside and they're trying to push in to the physician-patient relationship. And what we're really focused on is developing this advanced primary care model so that it's enhancing the relationship of the patient, of the physician at a community-based level. But it is taking all of these disparate applications, those that I refer to as shiny objects, and it's taping them together under one environment. So medication management therapy, any of these disease state management, chronic care management programs, wellness, why pay for wellness when it's all part of an advanced primary care model? Why pay for, chronic care management when it's all embedded within that primary care model? And then secondarily from there, the value of what I see in the self-insured market then is controlling the access and the referral process to high performance specialty networks. I think that is the next key aspect that's evolving rather quickly, is the prospective payment of surgical and non-surgical specialty services. So you're able to create prospective pay case rates so that if a referral is made, one, it's going to the right physician, but the referral is made under a environment in which the services that will be delivered and agreed to between the primary care, advanced primary care model and the specialty network is essentially prospectively known. You know what services are going to be provided as a consumer and what price before you get there. And so there's great opportunity in that regard. And ultimately that leads to the third component is what do we do about the hospitals and the acute care? We just showed you a good success model of a case that we've worked on for a number of years that has had high claims. But what do you do when you still have a group that's in a PPO environment and you've got off the chart cancer incidents, you've got off the chart illness, and we have an account like that right now that we're working on, and how do you move them from this prospective pay model, or excuse me, fee for service, and get them to adopt and get them to understand, and how does that impact ultimately the risk that you're trying to really focus on, and that's that acute care risk. Because you can deal with chronic care, you can deal with episodic risk, those patients that go in and out of the healthcare system, but they return to some form of normalcy. But those acute care claims, when you have a basic leukemia claim that did not even result in a bone marrow or a stem cell transplant, goes to $1.5 million under a PPO environment, something's grossly wrong with that scenario. But getting the employer's attentions and being able to validate prospectively that here's what you can expect and here's how you can turn to start to get results like what we just showed you from the account that we just looked at. That's, I think, the bigger challenge that we all have.
Steve?
Yeah, let me just amplify and kind of pull out one point in particular that Scott spoke to, and really just hammer home this point. There is no well-functioning healthcare system in the world anywhere that's not built on proper primary care. And a fully actualized primary care, that exists in some places in the US. You can go to places like Denmark. Fully 90% of the issues people enter the healthcare system for can be fully addressed when you have a fully actualized primary care. You may be stepping there, so you may not have physical therapy or behavioral health. You could still have a lot of benefit from primary care, so it may not be 90% if you don't have that. And it's really important to recognize it's impossible to price gouge on an ER visit that never happened. It's impossible to price gouge on an inappropriate surgery that never happened. We know when you have proper primary care, 50% of ER visits aren't actually emergencies. They're often people who have insurance that can't get access to primary care because we've systematically destroyed it over the last 2 decades. You take the second most common reason people go to the doctor, lower back pain. We completely botched that. It's the second most common reason people go to the doctor after cold and flu. #1 driver of disability, #1 driver of opioid prescriptions, even though there's exactly zero evidence that it's the most effective treatment. At best, it masks short-term pain while the underlying problem exists, and people get addicted or they get a surgery that they shouldn't have happened. Starbucks and Virginia Mason did a study. 90% of those surgeries never needed to happen. So you can get a lot of savings there. And then let me just zoom out for a bit in terms of, Scott talked about COVID and this kind of being this catalyst. I think what's different this time around is right now we have this confluence of 3 big factors. #1, COVID, right? COVID is, almost like a world war event. There'll be a pre-COVID world and a post-COVID world. That is happening. I think of COVID as a super spreader event on a set of societal pre-existing conditions that laid bare many of the failings that Scott touched on. So that's #1. That's one big confluence that makes it unique. #2, millennials. The oldest millennials are now 40, in their early 40s, largest generation in history, increasingly in roles of management. Does anybody think that our status quo healthcare system is even remotely designed for what probably any rational human wants, but certainly millennials want and value? And they're not only having their own, kids, their own health issues in a way that, unless they were unfortunate of a childhood disease they had, and they've got elderly parents, and they're going to demand change. They're the ones who drove, changes in food. So-called big food has had some of their worst earnings recently because of that. They drove smartphone adoption, social media, all that. And then the third big factor is these concepts that we're talking about here have reached a level of maturity that it's not just, you know, one or two outliers in some wacky corner of the country doing it. And what this points to is healthcare goes through a massive shift every 50 or so years. We're 10, 20 years late on that right now. And if you look about, you know, mid to turn of century, there's been these big pivotal points. We're in one of those, and we're going to be coming out of that. And so that's what, you know, anytime you have that kind of major transformation, there's big winners and big losers. Obviously, if you're on this call, you're wanting to lean into this. We know our system is broken. Fortunately, the fixes are there.
Yeah, good, Dave. Scott, I appreciate both your comments around it. When I see the provider community, and I'm going to take from the discussion that both of you ended with, is really the provider community and its reaction to you know, the changes that you're talking about, capitation, RBP. In our own experience, and Payer Compass's own experience with providers, from where they were early on in 2013, 14, 15, there's been a shift in mindset that there are, that providers have been more willing to understand an employer's perspective. And we have seen kind of an evolution of the provider community in understanding the concepts that, you know, for physicians, you know, the 27 cents on the dollar is what a physician's getting paid. That's shockingly low, what you would think as a provider in this system, right? And so my question for the two of you is, you know, I've seen it, you know, firsthand with providers coming around and being a more a better partner with our employer groups across the country. There is an opportunity to, you know, talk to them specifically about why price matters in terms of healthcare, but your perspective on what you see of the provider's reaction to, you know, to these concepts and the things that you just lined, you know, both of you spoke about.
I mean,
Dave, you want to go first?
Yeah, I mean, of course, there's always going to be laggards and leaders in this, and the leaders in any one of these shifts, you know, obviously end up winning out. And so kind of by definition, we're working with the leaders who realize that there's a better way. And guess what? They're all significant employers themselves that have healthcare costs. And sadly, a lot of the hospitals have cruddy health benefits for their employees. Way too expensive, not great primary care. And so one of the sort of overlooked areas that we are actually seeing some really nice activity around is healthcare delivery organizations as employers themselves saying, okay, you know, it's obvious that, you know, healthcare is not going to be 100% of our GDP, which is kind of what the trend line has looked like. There's going to be this new game. Let's build those muscles ourselves. And we're very excited about working with employers, provider-based employers who then can get that experience themselves. And then you go out to the market. You know, you're a multi-specialty group, you're a primary care group, and you say to your, and guess what? They all care for all the business leaders, union leaders, municipal leaders. They're some of the most trusted people in our community. They go say to them, hey, wouldn't you like to have the health plan that I provide to my family and to my workforce? And so then they develop those muscles that then they can take out to the broader market. That's one of the things that there's no doubt there's lots of great healthcare delivery organizations that we work with every day. You know, you are both familiar with just one employer, 5,500, you know, agreements. So there's lots of opportunity there, but I think it's go beyond that. And that's one of the hidden opportunities is healthcare delivery organizations as employers.
And I think I would add, you know, specific to Greg's question, one of the reasons we were able to achieve these safe harbor agreements at the rate and the number that we have is because we used plan data and historical information, and we created an allowable schedule for the physicians that was more fair and equitable than some of the other reference-based pricing models we see in the market that, in our opinion, and again, this is my opinion, are somewhat confrontational and somewhat draconian in how they establish what they reimburse physicians. And so, one of the key things is that, if you want to diminish disruption, you diminish 85% of it with the physician component, because that's where the primary points of access are for your membership, for these patients. And if you've got physicians who understand how they're going to be reimbursed, and they come to a conclusion that, wow, that's fair and equitable, actually could be more than what I'm getting paid in a PPO environment, and I get to then practice medicine, albeit fee for service still, but at a rate that allows me as a physician to charge, or not so much charge, but be paid more than what these other models basically put out there. Number two is that when you begin to move into the prospective payment environment, where you're converting from fee for service to a compensation model that's prospective payment on a per patient per month methodology, the physicians make a lot more money, and they have no downside risk than to where they are in the fee for service environment. So, that then gives that physician an extremely positive attitude toward the system, toward the patients, and it allows them to basically step back and have quality of life in their own lives that they're not getting in fee for service. The other thing, and this is really something that we're beginning to observe in the market, and it varies by marketplace. There was this movement that accelerated during the Affordable Care Act rollout, where there were massive amounts of money spent by these hospital-centric health systems, where they went out and bought up primary care practices primarily. And, in my opinion, the sole purpose of that land grab was to basically capture these primary care physicians as employees for one purpose and one purpose only, and that was to feed the specialty providers that ultimately put heads in beds and kept census at a high level. To me, in my opinion, that particular model's been a gross failure. And the other opportunity with prospective payment models emerging in the marketplace is it starts to give the employed primary care physicians and ancillary service providers a glide path out of those hospital-centric organizations back into a private practice environment that is structured, but also provides them economic safety and eliminates a lot of their downside risk, and allows them to go back to practicing medicine, whether it be face-to-face, whether it be virtual, or some type of access encounter with patients, and meeting them where the patients are and where they need to be. So I look at that as one of the more positive attributes of transitions that we're starting to see occur in the marketplace.
Well, terrific. Gentlemen, on providers, they are the key driver for us to be able to make the system, like you said, there are players that embrace it, Dave, and there's players that are going to be laggards to it. And we're really talking to the provider communities that are trying to be on the forefront of the very things that you guys are talking about. And Scott, I'm going to take us back to SIA Executive Forum, maybe 4, maybe 5 years ago, when you said, Greg, the good news with Dave and Scott is that you can always get a direct answer. That's what I like about it, right? You can you buy Scott a drink at a bar. He's going to tell you everything you want to know about how we can improve. And so I asked him, how can we improve?
2 drink minimum now, by the way.
2 drink minimum. That's right. It's a 2 drink minimum. But what I asked Scott was, what do we need to do around the provider, the provider acceptance and the patient advocacy process that we've gone. And he said, Greg, we've got to put more transparency to the provider, to the providers, right? We have to make it easier for our TPA partners and the members themselves of these plans in order to understand who these contracted providers are, because it's not a network, but it's not a network, right? It's a place where we want folks to go to receive their care in some kind of transparent way. The government has stepped in with transparency, and so I want to ask you guys about it. We have a tool, Compass Connect tool. I'd be remiss if I didn't talk about this transparency tool, both from an RBP situation as well as provider acceptance, as well as price, right? We're trying to help providers or help people understand what price is. And so what I want to ask you two gentlemen is, the government's trying to set standards around transparency. We have our own idea at Payer Compass what that means, and it gets manifested for our clients. But for you, in terms of healthcare transparency, provider pricing, where do you guys see this going in terms of industry versus government leadership? Well, what would you add or detract from either approach? Either one of you want to start on that one?
I would probably start by stating that I have no faith that the government is going to fix anything. Therefore, the solutions in healthcare have to come from local communities and work their way up, and then ultimately be able to be replicated in multiple markets throughout the country in a market-based environment. Dave and I have had this conversation numerous times, in that I believe in transparency, but I don't believe in how it's being defined in healthcare by opportunistic organizations that use the term transparency and pass-through as a marketing gimmick to create an illusion that there's value in what they do and what they provide and in their business models. One of the things that we are very disciplined, and when I say we, I'm talking about our national consulting practice within USI, the one discipline that we will not compromise is line item assessment of contracts, of data, and of the outcome that these organizations create. And there seems to be this absence of either capability within the brokerage consulting community, or there is just an absence of common sense that I don't care, for example, if you're a pass-through or a transparent PBM, and you are paying the client, paying the pharmacy what you're charging the client. If you're basically paying them 72 cents for a 40 milligram of atorvastatin, who cares if you're passed through? It's not a competitive unit cost price. And so when you go through this methodology of evaluating whether it's a PBM, whether it's a PPO network, whether it's any other ancillary service provider, it doesn't really matter what the discussion around transparency is if you're not achieving competitive results at the end. And so my point of this is that you have to be able to create contracts, and you have to be able to create metrics that are actually defined, are not variable, and that can be measured. And so that is a discipline that's just grossly absent in the healthcare environment, and it's horribly absent within the consulting community. So, that's one of the key things that we really support in what Health Rosetta is doing, is being able to work in a collaborative open source environment where there's an open sharing of information that, guys, it's not a proprietary secret to any given organization, but it is wisdom, it is methodology, and it is discipline that can basically be applied across all people that really want to make a difference to change what's going on in the environment.
Yeah, and I'd just add, it's great to have price transparency tools like you provide. I tend to fall in the same camp. I'm not counting on the government to do anything. When they do something, which the last administration did on price and transparency, that's terrific. Nothing wrong with that. But the thing that I would say is transparency in a true transparency is a concept you have all kinds of people talking about with provider pricing, and that's great. But a core tenet of what we're all about is broad transparency and alignment of interest. And this includes all the ways that people get paid in this industry. And that's really at the root of a lot of the issues when you're paid by the seller and you're representing that your interests on the side of the buyer. That just doesn't work. That is where, broadly speaking, if you look at all the contracts, whether it's a broker contract with an employer or various vendors, unfortunately, contracting norms in this industry have normalized deviance. So at a certain point, you got to take out the sword, slice through the Gordian knot, and do a reset. And that's what we see folks like Scott do, is like there is nothing to save out of some of these PBM agreements. You have to do a reset. And then you say, and I picked this up from Scott, if every CEO says employees are our most valuable asset, you should steward that asset very carefully. And it should be a privilege for the healthcare industry to serve that most valuable asset. And what you see professionals like Scott do is say, this is a privilege to serve our clients. We want to procure a service in this way, like you do for everything else in your supply chain. If you would like to participate, fantastic. Here's how to do it. If not, no problem. It's a free country. And one of the things that was interesting, Scott talked about PBMs. A lot of people beat up the big three PBMs. Well, if you know how to procure right, at least one of those three PBMs, you can get a good price. Like Scott said, there's no value in being a transparently overpriced. Like that's worthless. Let's get unit costs, go back to first principles and transparency, aligned interests. This is motherhood and apple pie, but unfortunately, if you look at like the plan sponsor bill of rights that we've published, the advisor compensation disclosure form, the advisor code of conduct, these are all motherhood and apple pie things. Unfortunately, they've been a perfect polar opposite to the way the industry's operated. That's why we're doing something different. And so that's to me where the transparency is really a game changer, is have those aligned interests. And we found up to 17 undisclosed revenue streams that the employers had no idea about. These are the types of things that are very fixable, but they won't fix themselves. You got to engage on it.
And the one piece I would add is that the ultimate form of transparency is competition. If you actually can create a level, unbiased playing field for competition to occur, prices will be driven down. But the only way to do that is it has to be exposed. It has to be exposed. And unfortunately, one of the biggest challenges I think we all face is the lack of healthcare literacy in our country, let alone literacy in and of itself. It's very challenging. I've shared this before in other presentations. We have an account in Oregon we manage that's 30,000 employees, in which we have identified 22 different languages being spoken. And so when you look at that kind of a situation where you've got this fragmented healthcare system that has no advocate. There's no primary care advocate. It's a free for all. You can go anywhere you want, anytime you want. You can walk in a ER and get served no matter what because of the way the laws are written. Not saying that they should be denied, but why would you go to an ER for a sinus infection per se, and that type of thing. But ultimately, it's competition that will drive prices. We see that in the procurement processes that we employ.
Gentlemen, I think our time is drawing to a close here. We want to talk, open it up and ask some questions from it. So we've got a little bit more time with Dave and Scott. And so let's see, trying to get to the question here. So one of the questions that we have from the group, what should we make of the recent news from Karam? They seem to be putting a lot of details together and raising a good sum. Do you have a solution that can stand the test of time? Is the question. You guys can see it on the monitor there. Anybody want to talk to the specific question that they have?
I really can't comment. I'm not all that familiar. I know who Karam is. We're active in that space. I'm not sure specifically what the questioner is referencing. However, what we are beginning to see in the marketplace, and this has been evolving for a while, is the challenging of the methodology through which claims are actually paid, and a major potential disintermediation of the carriers and third-party administrators in the actual healthcare transaction between providers and ultimately the plan sponsor. And whether this be a cash pay transaction or whether it be some modified version of that, but we're starting to see these technology companies, and quite interesting, these are not healthcare people that are driving these technology companies. These are people coming from different industries that have experience and insight into, you know, opportunity to basically get rid of that middleman in a healthcare transaction, so that it ultimately occurs between the patient, the provider, and then the plan sponsor. You know, the TPA payer will ultimately get a remittance advice that says, here's the transaction that occurred, you know, here's how you can capture that. But I'm not sure, Reggie, if that's what you're looking at, but that is something that I see related to any of these organizations that do case rates, that do bundles, that do alternative reimbursement and alternative site of service programs.
You know, my own experience around case rates and bundles, you know, since 2007, part of a group now called Alterum that does bundles. You know, what I would say is it's been a lack of providers wanting to do extensive bundles, right? So when for us at Payer Compass, the idea of bundles are not new to us. What is new is providers willing to contract on a basis that's going to be meaningful, right? They really want to do it from their own perspective of contracting rather than from an employer's perspective. And so we have specific ideas that we can help with and talk to specifically about what's a good what's a good bundle for hearts or the like. It's often what's in the bundle and what's excluded from the bundle. I can't speak to Karam specifically. Dave, anything you want to add to it?
No, I think that covers it well. I know we don't have a lot of time. I know there's another question, so happy to take that one.
Okay. The second question, we've implemented RVP in certain geographic areas with resistance that's very fierce. In other areas, we have little resistance. Can you comment on that? I mean, I can, but each of you have seen it played out on different vendors, including us. Dave, you want to answer the question first in terms of your experience?
Yeah. You know, one of the things I'd offer, if you go to healthrosetta.org and there's a button at the top that says get a book, go scroll down and get my latest book, Relocalizing Health, where the biggest chapter in that book is around change management, and that's how to thoughtfully roll out things. And in the back cover of the hard copy of the book, there's a 5-step process of how you transform health plans. We have leaving behind value extracting PPO networks as step 5. So there's 4 other steps that are either invisible to the member or clearly a positive. And so Scott mentioned earlier the shiny objects, right? That's kind of the way the industry has been trained. There's some new shiny object wellness programs, so-called transparency tools, whatever. And not that they're all bad. Some of them are kind of worthless, some are good. But you know, in some ways, RBP, even though it's a good thing, has almost become this like magic elixir that you don't have to be thoughtful on. In the hands of a professional, RBP, thoughtfully rolled out with the right kind of buy-in and the right kind of planning, can go great. And you actually have fewer balanced bills than what happens in the PPO environment. In the hands of somebody who's not experienced and just puts it out willy-nilly, you're going to have issues. But the other steps I outlined, some of which we touched on, these are things that don't change the member experience in any way, and other than positive. Maybe you reduce cost sharing on drugs, or maybe you provide great primary care. And then there's other stuff that's basically behind the scenes on contracting. So that's where I would say, like, don't just jump to the thing of, you know, you got to go to the high dive and do a triple twist with the gate, you know, spin, and to do it right. Like, if you have no experience in these alternative models, why would you start there? Like, dive off to the edge of the pool, maybe then go to the low dive board and then step into it. A lot of people just jump to this thing because it's kind of the hot thing at the moment, even though I think it will stand the test of time, but it's not in a magic elixir.
Yeah, and I would also add that related to this question, do your homework before you go down this pathway of advising a client to go to RBP or some other alternative reimbursement methodology. So as an example, we were looking at a client that came to us and said, I want to go full RBP. We said, okay, so let's study this a bit and see what's going on. We got their data and we went through a process. And then ultimately what we started to look at, you know, you had 2 hospitals and 2 systems in this particular city, both of which only had a market share of about 20% of their total revenue being commercial, meaning that the balance, 80% of their market share and their revenue as a system was coming from Medicaid or Medicare. And so when you look at that and, you know, the red flag went up, it's like, okay, we need to be pretty deliberate about having discussions with these folks before we go down this pathway. Because if you just pull the trigger at some arbitrary relationship to Medicare on an RBP basis in this town, you know, they're barely hanging in there, you know, at Medicaid, especially with the Medicaid level that they had within their revenue stream. That, you know, if all of a sudden you go in on the commercial marketplace and you're going to go into an RBP strategy and drop what you're paying, you know, from an allowable amount at 350% of Medicare allowed under a PPO, and all of a sudden you're going to be paying 140 to 160% of Medicare, you might want to sit down with that hospital and have a discussion with them first. And, you know, ultimately you end up at a higher level, but it's a lot lower than what the Medicare allowed would be under a PPO.
Well, thank you, gentlemen, for the comments with it. Again, Dave Chase, Scott Haas, appreciate your time today on our webinar. Hopefully everybody learned something, and you know, happy to catch up with everybody in the industry soon enough, right? So thanks again, Dave. Thanks again, Scott, and happy trails, and we'll see you guys very soon.
All right. Okay? Thanks so much for the opportunity.
Okay.
Bye-bye.
Thanks, everybody.